discuss with us. So first we'll go to one common thing that we see in our clinic, CSCR, the problematic commoner, by Dr. Suchitra Bhatt, retina consultant at Netra Jyoti Advanced Eye Care, Taliparamba.
Good afternoon all. At the outset, I would thank Dr. Natasha Madam for giving me this opportunity. CSCR is one of the fourth most non-surgical maculopathy in the eye. It is the most simple disease, but it's one of the most complicated disease. Today, as we are moving towards the pachychoroid spectrum, I'll be concentrating more of the simple facts which we are forgetting as we are moving to the pachychoroid era. First, my sincere thanks to my regards to my mentor, my father-like figure, Dr. Baby Bhatt. So moving on to the first case, she's a 51 years female. She's a very close friend of mine. She presented to me with diminished vision of left eye since 2 weeks. She had a history of using nail cream plus some face cream for 2 weeks and a history of some sleep deprivation due to night party at home. She has alcohol once in a week during parties and her visual acuity with +4 in right eye was 6.6 and 6.24 in left eye and near vision being N8 in the left eye. Amsler's gait was distorted in the left eye and she had a history of YARC PI done 5 years back. Anterior segment was normal, both eyes, and the right eye showed angioid streaks infratemporal to disc. This is the left eye of the patient, which showed typical CSR with angioid streaks, if you observe carefully, infratemporal to the disc. I asked her to stop the cream and come after 2 weeks, but still CSR was persistent. Not 2 weeks, actually 1 month, and she was very tensed about that, so I thought I'll do the FA immediately. So this is the FA of the patient, which showed a typical ink blot leak, which was very much away from the fovea. So I did the focal laser immediately. So this is after 2 weeks after doing laser, and this is after 1 month after doing focal laser, where she has completely resolved CSCR. So what was different in this case? So there was a hemorrhage in this case, which is very rare in a CSCR. Hemorrhage is very rare in CSCR, but it can occur as I went back and studied. It may be due to the abnormal blood vessel leakage or due to the high pressure in these fluid collection. This can cause disruption of the blood vessels, or it can be due to rib tears, which is secondary to CSCR. So hemorrhage in this case, it can also be due to angioid streaks due to the brittle nature of the Brooks membrane. So was the skin cream responsible for her CSCR? So I asked her to get her skin cream, which showed the content like glutathione, kojic acid, arbutin, vitamin C, etc. did not contain steroids. But as I discussed with my nephrologist, I came across these. Though these skin creams show these contents, actually they are finding out many cases which contain high doses of clobetasol, arsenic, and mercury. So I went back to the case and saw whether the skin cream was responsible for CSCR. She is a very non-anxietic patient, not a type A personality, happy patient. Will the alcohol or sleep deprivation would have caused a CSR? No, because she's been following up with me for past 2 years and she's continuing with the same life routine and she didn't have recurrence. So I discussed with the dermatologists also and they also told me the same thing. So there are some of the skin creams which these are some of the depigmentation creams which most of our patients are using and which might have caused the CSR. I don't know whether I can tell confidently, but the creams which I got through the dermatologist, my patient was using the Vita Glow cream. So I have an experience of around 10 patients who are using some skin creams which does not show the steroid content, but they are developing CSR. I just wanted to highlight this. Whenever you come across a CSR patient in your clinic, just stop any depigmentation creams they are using. So these depigmentation creams are very addictive. They give immediate results to the patient, and once they stop and they become dark again and again they start using. So better always to avoid this patient, and we need more studies to prove. If anyone has the guts and bold to go across these companies, we can work on it better. So this is my second patient. She's a 46 years female patient. She came with diminished vision left eye since 2 months. She has no systemic illness, very, very anxietic patient. She doesn't have any positive history of any medications, creams, inhalers, etc. Visual acuity in the right eye was 6.6 with correction, and left eye it was 6.6 partial. So this is the her fundus photograph and OCT, and left eye shows lot of fibrin. Since she was very anxietic, and this is the right eye of the patient, which she is asymptomatic, but still there is fluid there, which also shows a CSR. So since it is a bilateral CSR, I immediately did the FFA, and this is the typical ink blot beak in the left eye, which is almost inside the FAZ, and this is the right eye of the patient with the typical leak and lot of RP disturbances. So I convinced the patient to do the focal laser for the right eye, as there was lot of RP disturbances, and it was very safe to do as it was away from the FAZ. Left eye, I just gave NACDs, and I gave melatonin tablets for 1 month. So this is the right eye of the patient after 1 month, fully resolved CSR. And this is the left eye of the patient, which is also resolving, though there is fibrin, which is a poor prognostic factor. So one of the new things which I have found recently is that melatonin do helps in CSCR patients. It as I went back and studied, it is known to be linked to circadian cycle, and it regulates sleep. It is an antioxidant. It has an inhibitory action on corticosteroids. It helps patient if given at bedtime. So any CSCR patient, when you see when they are very anxietic, when they have sleeplessness, it is better to give melatonin at bedtime. You have nothing to lose by giving this. Improvements I have seen in around 30 to 50 patients. Maybe CSR is a self-limiting condition, but patients have a feel-good factor and they have less anxiety. So since this has less side effects, there's nothing to lose by giving this. So this is case number 3, where a patient has diminished vision both eyes since August 2023. She is a post-kidney transplant patient. She is on Visolon 10 mg since 1 year, and she cannot stop oral steroids as advised by nephrologist. So visual acuity was right eye was 618, left eye was 6.6, and dropped to 5/60 and 4/60 gradually. That was because of the post-subcapsular cataract, which we operated. And of post cataract surgery, her vision was 6.9 and left eye was 6.9. So this is the right eye of the patient since 2023 and 24, long standing CSCR in the right eye, and left eye also has developed CSCR. So how to manage such patients? We can't stop oral steroids, and how to go about it. Now there are many studies which show that intravitreals will help in CSCR patients. I personally don't have any experience. If the panelists or the audience have experience, we can go about it, or how to manage this patient where we cannot do a FA, she's not willing for Octa, we cannot stop steroids.
Very interesting cases, Dr. Suchitra. Let us, shall we move backwards from this one? So in a bilateral CSR, I think and you already have a history of steroid intake, you cannot stop the steroids, then you have to get an FA done, because that is the only way to deal with them. You have to find out the leaks and do a CSR laser wherever possible. Some leaks may be very close to the fovea, but whatever is away from the fovea should be lasered. We can also give a note to the treating physician that this is there, so they can reduce the dose to as minimal as possible to whatever. Most of them do that, or they sometimes shift over to some steroid sparing agent, because we can tell them that it will affect in the long term affect their vision, and they usually do switch. So that is the only thing. Intravitreal anti-VEGF, no, not for CSR unless there is a secondary CNVM for which the patient can. There is no features in this patient. I would suspect one in your previous patient, but not in this patient. There is no evidence of any CNVM here. So here we are dealing with a systemic problem that has caused the CSR. So at best, we have to manage the tightrope between the steroid intake and the CSR. About melatonin, can we go to this case? Is here, show me that OCT, please. Yeah. Here you can see that there is a definite small serous PED and that irregular RP there, fibrin there, because we know from previous scan that there was fibrin in the beginning itself. So that is definitely fibrin. But if it is not resolving or if there is intraretinal fluid, I would ask for an octa for this patient because you may be missing a long chronic CSRs can produce CNBMs and you may be missing that, and treating just with placebos when the patient actually requires intravitreals. Melatonin, I personally I have not given to any patient, but it is a non-addicting sleep helping drug that is now freely available and can be given in a low dose. Yes, if you have a good rapport with your patient, generally I try to avoid antidepressants and such things from our side. If you think the patient is anxious, they should go to a specialist and get the anxiety sorted out than us giving something. From our side, we can give our placebos and not the other one. If you have a good rapport with the patient, yes, melatonin is a safe drug that you can try. Face creams, just to be, you've just scared me now. What about all my anti-aging stuff that I slather on? And the husband says that I'm poisoning him. Yeah. So, yes, I routinely ask for face creams because a new onset face cream use and then CSR, because a lot of absorption through the skin. Even other creams like eczema, everything should be asked for. The first CSR patient who comes into you, don't just dismiss it as CSR. You should ask them, what have they started using recently? Any Ayurvedic medication, any skin cream, face or otherwise. Sometimes they put for, thick skin or like hyperkeratosis somewhere, and then that is a steroid cream. So you can ask in detail history of that. Ask them to stop it. That will help you in managing your steroid patient.
Yeah, this is just a summary, but one new thing I want to tell is there is a new concept called as familial CSR. We have to think more about this. Studies have shown that where the siblings are developing CSCR, and I had a patient where husband and wife both developed CSCR simultaneously. So we have to think in that direction.
Causing mutual stress.
And the husband developed recurrence after 6 months. Luckily, the wife didn't develop recurrence. So,
Shall we take doubts from the audience?
yeah, any questions?
Okay. You can fit the last slide.
Yeah. So this is just, I just want to highlight, as we are going to more complicated things, octa and this thing, don't forget to have a chair time with your CSCR patient. It is very, very important. Even crash diets, jet lag, lack of sleep, any infection, for example, it's a stress for the patient. So always don't send it to your counselor or this thing. You yourself talk to them for 10 minutes and then send. That makes a lot of difference. So any questions?
Any doubts from the audience? I think we have a record audience here. We should take a picture. But I'm so sorry that you don't have seats. Can the hall management do something about it?
There are some seats in
We still
between.
have 1 hour, no? Some more extra chairs, maybe even just plastic chairs.
Here, there are
Any doubts? Anything that you encounter in your this is like this is just a simple session. Nobody is going to judge you. You can ask anything. Yes. Again, indomethacin and other NSAIDs have no proven role in CSCR. The pachychoroid spectrum is what is causing it. So they are actually prone to develop from both the choroid side and from their mental side. So that is what is causing it. Eplerenone, yes. For chronic, for CSRs that are not resolving in 3 months, I usually do a FA. And if the FA is, we cannot do the laser, then I do try eplerenone. It is not a panacea. It doesn't work in everybody, but it works in some people. So you can try that, monitor your RFTs while you're giving. So if you're giving it for more than 2 months, definitely get an LFT, RFT done when you're giving that. It is like a spironolactone kind of diuretic. So you need to be aware of that when you're giving. But you can give, I usually give 50 mg OD eplerenone. Then any other drug, what do I give when a patient comes with CSR? Anybody can guess? Yeah, just the usual placebos that we give in our off-thal OP and tell them that it will cure. That is more important. Give them confidence that it will go away. So don't tell them that, oh, idinu marunonnum illa. And that will just stress them out even more.
One more thing is we have to explain is contract sensitivity comes back to normal only after 3 months. So patients keep on complaining. So tell them that it takes 3 months for the, even though the CSR is resolved in OCT, it takes 3 months for the contract sensitivity to come back to normal. So just explain so they'll understand.
And always tell them that it will resolve, especially first timers. Just give them some confidence and then it gets better much faster. So, so whatever you want to give in your plethora of the antioxidant drugs that we have, you can give. But whatever you give, you tell them that idu kadicha madi oru masam maarikolum.
There are some seats in the front room.
I usually call back after 1 month. No. See, first episode CSR is not going to cause a CNBM. It is going to go off. And recurrent CSRs, or if you see any change in the CSR, the things that you have to be conscious about when you're following up a CSR patient is their intraretinal fluid. Intraretinal fluid is a sign, one, of chronicity. It can be there without a CNBM, but you have to suspect a CNBM. And also if the RP is irregular and it is showing signs of fibrovascular PED.
Yeah, ma'am, I have a doubt. What is your experience in giving spironolactone for recurrent CSR?
As in the spironolactone?
Yeah.
No, I have not given. I have given only eplerenone.
And how is it? How is it working?
Eplerenone works. We answered that question before. It works in some people, does not work in others. Don't continue for a long time if it's not working. Okay. Try for 2 months. If it's not working, you can stop.
Eplerenone helps more in patients who has fibrin and such biomarkers. So better to start in such patients. So when you have fibrin, eplerenone is known to work better.
And what appears to be bilateral CSR, again, FA is very important because in a bilateral CSR, you may be looking at something that is not CSR at all. So it may be just a multifocal CSR, but it may be an early VKH. It may be a paraneoplastic syndrome that is causing it. May be TB. So do not think that all SNDs are CSR. So SND, any atypical feature, especially multilocularity and bilaterality, has to be investigated with a fluorescein angiogram. Yes, Suchitra.
Yeah, I give it for 3 months usually. Yeah. So, dose is 3 mg of Mactone. You get these multivitamin, tablets. One of the tablet I give, I don't have any personal interest, MacuGold Plus, which has melatonin plus all the other antioxidants in that.
Oh my God, they're going to give you something. Yes. Now the conventional thinking of, you wait for 3 months and then only do FA, all that is changing. You can do FA if it's a large CSR or even a small one in a patient who wants faster visual recovery. There is no harm in telling them that we can do an angiogram, find out where the leak is. If it is laserable, we can laser it. We should not say that, okay, namakadu cheyyam parayanda, but at least you can tell them that, let's see. Especially these IT professionals who really can't work with that CSR. So you can do an early FA if it is not resolving. I think we should stop and move on to the next talk.
Just one slide. We just want to invite everyone for the CME on uveitis, which is on January 4th and 5th. Please do come.
Here in Kochi, jointly organized by 12 of us from Kerala.